Well, good afternoon. My name is Mike Mack, and I'm a cardiac surgeon from Dallas, and we're here at the Society of Thoracic Surgery meeting in Los Angeles, California. We're going to have a panel discussion today on the treatment of aortic valve disease, mitral valve disease, through the mechanism of a heart valve clinic. We have a very distinguished panel with us today, all of which have a lot of experience in heart valve clinics, and we're going to learn from their expertise and their pains in terms of how to build a heart valve clinic and how to treat patients with valvular heart disease. I'd like to start on my right here. Wilson, would you introduce yourself to our audience?
Thank you, Mike, and it is a pleasure to be here. My name's Wilson Zito. I'm a cardiovascular surgeon at the University of Pennsylvania in Philadelphia.
Herman?
Yeah, my name is Herman Lorraine. I'm an interventional cardiologist out of Aspiros Wausau Hospital in northern Wisconsin.
Chris?
My name is Chris Malacery. I'm a cardiac surgeon, Northwestern University, Chicago, Illinois.
Tim?
Thank you. My name is Tim Foley. I'm a nurse practitioner, and I'm the clinical coordinator for cardiovascular and thoracic surgery and valve clinic coordinator in Las Vegas, Nevada.
So Tim, let me start with you. Since your day job and prime job is to run a heart valve clinic, can you tell us a little bit about what your clinic is like, who staffs your clinic, and how you got it going?
Sure. I think to begin, we started the foundation of our clinic based on a quality initiative that was driven by the hospital that really focused on identification of patients with severe valvular heart disease that presented through our facility's doors, regardless of presentation or mechanism of presentation to the hospital, focused on identifying them through inpatient echocardiography, and then ensuring follow-up and the appropriate referrals to both cardiology and cardiovascular surgery. I think operating from those basic starting points, we were able to generate enough interest and demonstrate enough support from both cardiology, primary care, and cardiothoracic surgery to implement a bi-monthly valve clinic.
Bi-monthly?
Correct.
So how long does your clinic last? How many patients do you evaluate, and who staffs your clinic?
So our clinic is staffed by a nurse practitioner, myself, physician assistant, and then we have two cardiothoracic surgeons that rotate through clinic. It's held twice a month. We see approximately a dozen to 2 dozen patients. I would say since we're in the beginning phases of our valve clinic, approximately 70% of these patients are new patients that we're seeing initially referring over from the hospital and identification through our inpatient echocardiography lab, but now we're starting to see patients being referred from cardiology and primary care as well.
Herman, could you tell me a little bit about your valve clinic?
Sure, ours is a little bit different. We run it also twice a month. We're staffed both by cardiologists and surgeons, so we have 2 surgeons that alternate and 3 cardiologists mainly that see the patients together. And we basically what we do is evaluate a patient comprehensively, do whatever testing is necessary on that same day, and come up with a plan at the end of the day for the patient. We have 3 patients every day and then an urgent slot for a 4th patient if needed.
So Chris, in the early days of TAVR, there was a question about whether aortic valve disease was undertreated or not. And I think all of us have learned that there were a lot of patients that never crossed the surgical radar screen because primary care physicians, cardiologists, screened them out and felt they weren't candidates for it. How do you identify patients with severe aortic stenosis now? We know there's a lot of programs in hospitals for alerts for critical values, and now that many centers are establishing echo alerts for anybody that has a severe aortic stenosis, automatically somebody is notified. What's your sense as to how undertreated aortic stenosis is, and do you have such a program in your hospital, or how do you identify these patients?
Yeah, so our program started out of the simple question about whether or not we're actually following guidelines, and our chief of cardiology at the time was Bob Bonnow, who headed those guidelines. And there was data out at that point to suggest that a lot of patients were untreated. But of course, at your own institution, you never believe that to be true. So we did our own data search and found that a good amount of patients, up to 50% of our patients, weren't treated as well. So we started with a echo alert system, and I approached our head of echocardiography. And basically, any time an echocardiogram that was done that showed there was severe valve disease, then that echocardiographer who was reading the echocardiogram would go ahead and call that person who ordered the echocardiogram to alert that physician. Much like a quality initiative here, because if you couch it in sort of those terms, then you get out of sort of HIPAA type stuff.
So Wilson, how do patients know about your valve clinic?
That's a great question. Fortunately, Penn has been a leader in our market with valvular disease. But having said that, we continue to strive to be better through education, not only for patients, but through education of referring physicians. We use, and in this age, we try to use internet-based media to help educate our referral physicians. But it is also with the help of published data on the new technology of TAVR that we try to encourage and educate our referring physicians.
Tim, could you expand upon that a little bit? I mean, how you do educate primary care and referring physicians about how to manage patients with aortic stenosis and when to refer into a valve clinic?
Absolutely. I think what we found to be most impactful in our market was utilizing patients from our retrospective review, patients who had come through our facility who had been demonstrated to have severe valvular heart disease, and for one reason or another had not been referred to cardiology and cardiothoracic surgery for evaluation. We brought our primary care physicians together. We had a guest speaker that would talk about the prevalence for valvular heart disease and the subsequent underdiagnosis and undertreatment. But then we shared with our primary care providers their patient story and their patient's data, and demonstrating that these are your patients, and there certainly is an opportunity here for us to provide better evaluation and hopefully subsequent therapy options for our patients. And so that way it's a very non-threatening way to provide information on the current evidence-based medicine and the applications that we have with emerging technology such as TAVR.
So I think all of us started with valve clinics for aortic valve disease. Does anybody have a mitral valve clinic also?
Sure. Yeah, we do. Actually, our valve clinic is not an aortic valve clinic. It's just a valve clinic, period. And we try to tackle any complicated valvular problem, and we defer back to cardiology any simple valve problem, a straightforward valve problem, because we don't want to be seen as competing with cardiology. So we only tackle complex valvular patients, mitral, aortic, multivalvular disease. And as I said, we see the patients in one day, and then we send them back with a plan to their cardiologist.
So Wilson, your aortic valve clinic has probably evaluated well over 2,000 patients now. Can you give us kind of a snippet of, just say, 10 patients? What'll happen to those 10 patients? Do they go to TAVR? Do they go to surgery? Do they get medical therapy? Do they, what is kind of the breakdown of what happens to every 10 patients that come into your clinic?
That's a fantastic question. And we have been busy in screening patients for advanced aortic stenotic disease. And ballpark figures, believe it or not, the majority of patients do not end up having TAVR for a variety of reasons. They could be on one end of the spectrum, risk profile was too low to feel to be we would receive benefit from TAVR. And also on the other spectrum, which all of us have seen, are patients that are too high risk, too far gone, to point of futility, but we felt that TAVR would not provide any benefit because their patients are just too far gone to so-called cohort C. Now, the majority of patients through our valve clinic still, I would say, end up having traditional, conventional open surgery. Now, it could be minimal invasive aortic valve surgery. It could be traditional full sternotomy aortic root replacement for whatever reason. But the majority, I would say, still 60 to 70% of our patients end up having some sort of conventional surgical intervention.
Chris, where do your patients come from? How do they know about you? Do they come from referring cardiologists? Do they come from primary care physicians? Do they find you on the internet?
I think all of the above. I think the biggest point with the valve clinic is to sort of focus at home first to make sure that you're capturing all the patients that are being seen in your own institution. So hence the echo search, the echo alert is very important. Once you've focused on that, I think then it's fair to go out in the community and promote TAVR or sutureless valves or any sort of percutaneous or new technology. But I think the point is to stay at home and look at the mirror first before you start looking outside referrals.
Mike, and if I may interrupt, Chris, you've mentioned twice about the echo alert system. I think that, I want to expand a little bit on it because I think that the echo alert system is very important, but you don't want to just do it when patients have severe valvular disease. You want to start much earlier. So we've all seen patients that have an echo 10 years ago that shows a mild aortic stenosis, and now we're seeing the patient with heart failure, advanced valve disease, and decondition, not a good patient. So what we've done for the last 4 years is just follow the guidelines. The guidelines of the American College of Cardiology are very specific. If you have mild aortic stenosis, you get an echocardiogram in 3 to 5 years. If you have moderate mitral regurgitation, you get an echocardiogram in a year, and so forth with the different valve problems. So we follow that, we put that in our report, and we make sure it's followed. And when we see a problem such as severe mitral regurgitation with depressed ejection fraction, we put right in there, refer the patient to cardiology. And so we have a very high degree of compliance with that program, and we get a lot of patients that way.
Tim, how do you communicate with the physicians that refer to your clinic? What is the follow-up feedback that's given back to those physicians?
The feedback we like to think is comprehensive. We communicate with providers both via telephone. All patients at all points of contact within our echo alert protocol and our valve clinic, the providers receive written communication. So we have templates that we use for all different types of valvular heart disease that include current recommendations, ACC/AHA recommendations, specific patient findings to communicate to their PCP, as well as consensus recommendations from our valve clinic back to both primary care, cardiology, and information for the patient as well. And touching on what both Chris and Herman had spoke about earlier, developing this quality of an initiative at your facility and reaching out to the community, these are not mutually exclusive events. I think starting at your facility, being able to identify patients and ensure patients that have severe valvular heart disease to begin and ensuring that they are receiving appropriate evaluation helps you establish a rapport with your referring community and your primary care community and helps educate them little by little over time so that they are up to date on current evidence-based medicine for valvular heart disease. And I think those are very important things. Be smart about.
So Herman, if you were giving advice to a center that was going to start a new multidisciplinary heart team clinic, what are the 3 key things you would tell them that you've got to have to be able to get this going and be successful?
Yes, so that's an important concept. When we started thinking about putting this valve clinic together, we came together, surgeons, administration, and cardiology, 3 separate groups who were not integrated back then. And we came together and started the discussions, and we realized, for us it was very important that the cardiologist and the surgeon saw the patient together and had the discussion what was the best therapy for the patient. It was also very clear that patients were going to need an extended evaluation, a lot of time in the clinic. And it was very clear that cardiologists cannot afford to do that from the time constraint point of view. So we came out to the hospital and said, well, the hospital decided that we're going to hire a cardiologist, to spend time here in this valve clinic, 1 day every 2 weeks, dedicated exclusively for the valve clinic, and we're going to take the money out of the equation. And the surgeons, of course, it's in their best interest to be there, and the hospital provided all the facilities, a valve nurse, and administrative staff. We actually did an analysis of our performance, and that was published in the Cardiovascular Business. The downstream revenue that such a clinic generates, actually, it was good business for the hospital as well. So I think that patients benefited, we did fine, the surgeons and the hospital. True win-win.
Yeah, I think the key that you mentioned there is you got to have a mechanism of capturing what the downstream revenue and business is to an institution from that. And that's how you make your case to get the clinic billed. I think that's absolutely key. So Tim, do-overs. If you had to do it again, what would you do differently?
I think we would have done it sooner. I think we had looked at this problem numerous times. I think it's difficult to bring together administration, cardiology, cardiothoracic surgery, and get everyone motivated. I think at the end of the day, we look at the benefit that we provide to patients. I think operating from that foundation of trying to make sure patients have access to experts in cardiology and cardiothoracic surgery, I think we've seen the benefit from that. So I think we would have pushed harder to get it moving more quickly.
Chris, is this a long-term strategy that's going to survive, or is this just kind of a warm and fuzzy thing that everybody's feeling right now?
Well, I think it's going to survive for two reasons. The first reason is it's in AHA and ACC guidelines that Mike, that you helped draft. And second of all, this is just not one act, but it's sort of a habit that you have to do over and over again. It really is a quality initiative, so following up on data, getting reliable data every year, every week, every month is important.
Yeah, Mike, as we're having more competing technology and between surgery and cardiology, and we are having patients that can go towards the traditional surgery, they can go the interventional cardiology route, they can go the combined way. And this not only applies to valvular heart disease, also for coronary artery disease. I think we're all moving forward towards the concept that you're seeing in Europe. There's a heart team, and they get together and decide what's best for the patient. And I think we're going to be moving towards that as well.
So Erman, you're at a surgical meeting, and you're our cardiology guest here, and to show that we are the perfect hosts, we're going to give you, as a cardiologist, the final word.
Well, thank you. Yeah, just to reiterate what I said, it's really important that we work on this together with the patient being, the focus of all of our attention.
Well stated. So I would like to thank all of our distinguished panel for what I think was a very, very productive discussion, and hopefully gave our audience a lot of insights into the current state of the management of patients with valvular heart disease in a multidisciplinary heart team clinic. And I would like to thank all of you for participating, and I hope the audience finds this of value.